Mostly gone. But just,
It's a little quiet in here today. What is it? Everybody must be enjoying the holiday meeting of the Buncombe County Health and Human Services Board, regular meeting to order. In accordance with the State Government Ethics Act, it is the duty of every board member to avoid both conflicts of interest and appearance of conflict. Reported, hearing none. Let the record show that no conflicts were reported. You have before you the minutes of the December board meeting. You will recall because of some other issues, we didn't have a January meeting. And because of other things while we were on this, I would remind you that we won't have a March meeting. I think everyone has had that communication. So let's look at the December 2015 minutes. Is there any corrections or additions to those? If not, I'll entertain a motion for their approval.
Second.
Been moved and seconded that the minutes of the December 2015 board meeting be approved. All in favor say aye.
Aye.
Opposed? Motion carries. I have to remember to sign these, so once we approve them, but there's no evidence except the video. Okay. Jennifer's going to give us a financial update.
Good afternoon.
Good afternoon.
You received in your packets the financials for the through January 31st, 2016 expenditures. We are 7 periods through the fiscal year, and 58.3% will be our target for the 7 months. You can see we continue to do the initial slide for DSS and public health as it exists. And then we, on a subsequent slide, give you the information about the one-time expenses that are amortized. What you'll continue to see as we progress through the fiscal year, that second slide is less impactful. So the percentage difference decreases as we progress through the fiscal year. You can see here for DSS, all of our expenditures are on target. The contracts are going to be related to those that we pay out. You can see the Home and Community Care Block Grant for Orlando Sky is now already 100% fully paid. And here it is with the one-time expenses amortized, and you can still see that DSS is still on target for expenditures. Any questions? So here we are for public health without the one-time expenses amortized. You can see that the salaries are slightly above the anticipated target. That is related to 4 total positions that we pay out of the health budget that were originally budgeted in DSS. Those are 2 environmental health positions and the 2 that sit in the admin budget for interpreters. That's due to the need to shift resources from one part of the organization to another for work. I'll go ahead and I'll show you the one where the expenses are amortized. The school nurse contract, again, is just related to we front MAHEC dollars for the operating budget for the full fiscal year expenses. So, any questions? Thank you.
Thank you. We have had a lot of activity in our organization, and we thought today would be a good time to sort of get some where have we been, where are we now, types of information from several of our agencies. You have, Amanda, you start? Rachel, I'm sorry.
Amanda will be in just a minute. So, as we went through the last year, we covered a lot of topics as a Health and Human Services Board across our division areas of social work and public health and economic services And one of the ideas that had come up last year was to come back together every 6 months or so and revisit where we've come, hear updates on projects, and look at what priorities we want to focus on in future months. So that's what we'll do, is each of the division directors will share updates on previous topics that we've discussed as a board, and then also, as they go, emerging issues, topics to watch. We have left these little sticky dots at each seat, and so as emerging issues are presented, we'll make sure that they all get captured, and on the way out, we want you to use your sticky dots to indicate what are some topics that would be good for us as a group to dig in a little bit deeper together in the coming months. Before we get into specific revisions, Amanda Stratton is going to talk to us a little bit about the website, which our board website, when we rolled it out, we got really good feedback about it being a really easy to use tool, but some of the technology caused us some challenges. So what can we do to refine it, make sure we're using what's there, and make it as useful as possible.
Thanks, Rachel. Before we get started on feedback on the website, I wanted to point out a couple of new things that are on there that you might not have noticed. And those are some of our major reports. Those are in addition to the reports that you receive on a monthly basis. Our annual report from fiscal year 15 is on here. You can download that and review that information. The budget guide for fiscal year 16 is also on here to download if you're interested, things like that. And our program and fiscal improvements document, sometimes referred to as the HISPI doc, is on here. It shows information from the past several years and how it's benefited the organization. So one quick conversation, I just wanted to open it up. I know that even today we had a little bit of a trouble getting signed into the website. We welcome your feedback on that. It might be worth considering opening it up as a non-secure website. The information that's on there, we thought initially would be stuff that would be sensitive, but it's really information that is most public anyways. So, and if you all have any other feedback items you'd like to see on there, I would like to open the floor for conversation on that.
I've never had any trouble at home getting access. It's here, so there's something in this building. I'm thinking that maybe interfering with our access.
Yeah, we don't have problems on our computers in the office either, so it might just be something we bring up with IT again.
Yeah.
Maybe the devices that we're using as opposed to the
Could
site.
be, who
That's right.
knows?
Any other feedback? Anything that
I'm
would be
just
helpful to have?
reminded of the report which we received in the hard copy as well. I want to commend the staff for all of the excellent work that was reported there. That's always a nice PR piece to see the results of your report. And I think we commend you for all the work that you did and what's reported in your annual.
All right, well, we will continue working with this site and let us know if there's anything that you would like to see on there in the future. At this time, I'll pass it over to Tammy Shook, our social worker director.
Sana, just while Tammy's coming up, make a point, what division directors are focused on their issues the board had interest in and asked for presentations on in the last year? So,
So before I get started, we're going to let Rashida talk about some of the work that Brooks did.
Good afternoon.
Good afternoon.
I'm Rashida McDaniels, and I'm the program manager for our community and family networks. And on my team, I have the Minority Health Grant, I have the Community Service Navigation Program, I have Children Under 6, which that'll be a focus today, and a community health nurse on the team, and 2 of my social workers from Children Under 6. So, I don't know if you realize this, and as I was looking through the data, these are several of our beautiful brochures completed by our communications team. And my community service navigators and children under 6 take these brochures out to any families with children under 6 in our community. The Children Under 6 program, my social workers receive those cases when someone from our community calls to make a child protective service report and it doesn't meet the statutes of neglect, abuse, or dependency, and the child is under 6, the county will send out a social worker to that home. And what's good about this is that even though it might not be a point where it's involved in child protective services, our social workers are able to go out there and do a complete assessment, a health assessment, and figure out what the needs are for the family. I read some of the statistics, and within the last 6 months, which is a great deal of concern, is that the children who have entered into foster care, within this last 6 months, 70% of those kids are children under 6. So 70% of those kids are children under 6 within this last 6 months. And Tammy will talk a little bit more about that. So what has been decided is that my team will be realigned, and my team is going to focus on infant mortality, preconception health, and we want to really take heed and be a support, especially of mothers who are dealing with substance abuse, and we want to develop a safety net for that family so we can feel okay and mom can feel okay to be able to take her child home. So we're going to have a whole team of that. And my team looks at families in a holistic way. We not only see and provide services to children under 6, but if a family is dealing with homelessness, or if they can't have access to food or any other issues, my families and social workers are looking at those families that are in a holistic way. So that's what my team will be doing. We're excited today. We're starting a partnership with the YWCA. We're going to start a Safe Sleep video today. And we have some parents in that community that's willing to step up and talk about that.
You said it's safe?
Safe sleep, yes. And meaning safe sleep is that we don't want, and I can talk a little bit about, I don't want to misquote the deaths in Buncombe County that a contributing factor with safe sleep. We don't want parents rolling over on their kids, and that has caused a lot of children to die. And our county wants to prevent that. So my team has been challenged, as well as the community, to figure out the barriers for these families and figure out how we can be of support and continue to be support in our community.
And CDC identifies suffocation as one, for rollover suffocation is one of the 4 top drivers in infant mortality in the nation.
And the beauty in this too, since I have RN on my team, we'll be able to go to the homes and figure out if mom has a place for her child to sleep, and what are the other issues that this mom may be dealing with. Because it's stressful to take a new baby home, especially when the baby's dealing with withdrawals, and we want to be of support to the mom and the baby. So here we have the child abuse PSA, and this PSA was shown to child care providers in our community with a partnership with Smart Start. And during this PSA, before they showed it, they showed invisible thread, because we wanted to encourage parents to write immunizations for their kids. So this just talks about child protective services and the importance of making reports, and how a social worker is, and just some of the risk factors that we have to deal with in families dealing with child protective services.
We have almost 5,000 cases of child abuse reported each year in Buncombe County alone, which means that there's 13 cases right now that are being called in today.
I think abuse is something that people just don't want to talk about because they don't want to know that it occurs in their community, but in Buncombe County it occurs through all communities, all education levels, all racial demographics.
The indicators of child abuse sometimes are not as obvious. It might be a child who's sleeping in school, a child who's used to be outgoing who now is less outgoing or kind of closed up. It may be a child who acts very hungry at school because they're not getting enough food at home. We also have head trauma, broken bones, children that are sick and are medically not taken care of at the level they need to, not getting to the doctor.
There might be a mark, or there might be a bruise, or there could be even an injury, and the reality is those things heal much more quickly than the emotional piece. One of the things we constantly deal with in child protection is trauma. We know that abuse and neglect causes trauma. We know that sometimes when we have to remove kids from bad situations, that can also cause trauma.
There have been studies that have shown that having adverse childhood events or traumatic events that happen to you when you're a child significantly increase your risk of all types of chronic disease, obesity, lung disease, lung cancers, all different types of cancers, suicide, depression, all types of different mental health issues.
When children are in those first couple years, those first 5 years, their brain is developing like crazy, and the more that child is in an environment of kind of fear and uncertainty, that affects the development of their brain.
Children under 6 actually make up over half of the reports that are called into DSS. And unfortunately, children under 6 actually make up almost 86% of children who die from child abuse or child maltreatment. These are children who, a lot of them can't talk, they can't communicate with us in regards to what's happening to them at home or elsewhere. They aren't in daycare, they're not in school. There's no one else who is looking at this child or keeping an eye on them to make sure they're safe.
I feel like a lot of people don't want to get involved, or they don't have all the information, so they're fearful of making a report because they don't want to make a report when it's something that can simply be explained. Allow the department to look into that. You would rather be safe than sorry.
We're already seeing the impact of children that have been abused and neglected now by the increase of numbers in our prison, by our unemployment rate. We need healthy leaders, and it's our children that are going to make the difference. And they are relying on us to keep them safe so that they can become the leaders, the community members, the parents that they're going to become one day.
The suggestion for the video came from the board. So that's one of the board meetings.
We're taking this out in the community. So it just shows that it's not just our responsibility, it's the community's responsibility to figure this issue out. So at the editing center with my community service navigators last year, we had 100 people to participate at the editing center in an open space model. So we had 4 specific topics that we wanted to discuss during this open space. So during the open space, we have specific things we want to talk about in small groups, which wasn't a really small group during that time, so it was 100 people. But we got a lot of feedback from our community. So the 4 topics that we discussed was unrelated caretakers, unsafe sleep, welcoming neighborhoods, and strong families. So what my team does is that we go out to all the communities across Buncombe County. We do a lot of surveying. We try to figure out what do people need, and at the same time, we give out information what's important from Health and Human Services. So when I went out there and spoke to these 100 people and talked about child fatalities and children's death, and explained to them it's not only the department's responsibility to make sure children are safe, it is our community. So what are we going to do as a community to decrease these number of child fatalities in our community? So we got a lot of input from the community. So this year, I'm going to take the input that people gave us and try to be strategic in the communities that we're working in to try to decrease infant mortality, especially the higher rates of African American communities that are 32.4% higher than any other race in Buncombe County. So these are some of the voices of our community that night.
We have a little drumming program down at the Grant Center now that some of the children are in. It's good. A Girl Scout program that just started. And some of the ladies here, we're, trying to get some other things going, mostly for the children, because they need to be steered in the right direction, get off the streets, and educated and stuff, This is a good neighborhood, a lot of good people in it, and a lot of people that try to work with children and do so.
I would like for our kids in our community to have more positive things to do out there instead of just hanging around, not doing that and getting in trouble. But other than that, it's a great community that I stay in.
I'm a single father, and I have been a single father for the last 14 years, and to me it's been a joy and a privilege to be able to be there for my son and do for him the things that my father never done for me.
The kids get to come together, kids that didn't know each other because their parents is up there, so all the kids is playing at the park. I mean, there's a lot of different cultures out there, and they all just get along. Even if they don't speak the same language, they play the same games.
Questions for Rashida? Just one clarification, the under 6 program is a prevention program, so it's voluntary, it's not involuntary. So when Rashida's staff go out on the screened out reports, they do that in a voluntary way. So the family has to agree for them to come in and do the assessment and work with them. But we are seeing positive outcomes from those families.
Rashida, do most families agree to that, or they welcome you?
I wish I had the statistics. Most families do, but the issue is that we can work with these families for 90 days, and sometimes it takes longer than 90 days. So with the realignment, it's going to allow us to do that. That's what the families want to do. Yes. We have 2 great social workers that are very passionate about this, and they want to be able to do case management with families and really truly figure out the needs.
I really liked your video. That captures, I think, the essence of what I thought we were to be showing to the community. So that's really an excellent response to our previous conversation.
You wouldn't believe just the conversations we've had when we showed them the statistics in our community, how many people wanted to do something different to make sure kids are safe. So we're going to really work hard to do that. And everybody have different ideas. And the great thing about it is that we have different chances to be creative to make changes in our community. So that's the beauty of it too.
Thank you for what you did.
Thank you.
And just to pick up where Rashida left off, I was privileged to be at the Eddington Center event, and I led the group discussion on safe sleep. And so I'm going to spend just a little bit more time talking about that. This is another great production from our communications department to really show what safe sleep looks like. And so at the Eddington Center event, we had a pack and play with just a sheet, just like that, and a baby doll in it. And as people approached my center, I just said to them, what do you think about that? When you look at that baby in that crib, what do you think? And I heard a lot of, it looks cold, it looks like someone doesn't care about the baby. And so I tried to explain to them one-on-one, and these were a lot of grandmothers in the community that were saying this to me. And so I tried to explain to them about safe sleep, and why, those wonderful layettes that they sell you at Babies R Us with the bumper pads and the matching comforter and all of that, it looks great in a magazine, but the reality is that all of those things are traps and can cause children to suffocate in their crib. And so I got the same reaction that Rashida is describing, where people were like, oh, really? And I said to them, you're who young moms come to for advice on how to raise their babies. So it's important that we get this information out, not just to prenatal situations, prenatally, but really to those grandmothers in our community, those people that moms go to and say, what do I do with my baby? And so in that vein, we've really done a lot of research around safe sleep, talked a lot about safe sleep, and one option that we were excited about is an option that's actually used in the country of Finland, where every single newborn baby, regardless of economic level, is sent home with what's called a baby box. And it looks like this. And so when you take the lid off and you look inside, it's got a little padded place. And in Finland, they send these home chock full of baby items. You know, it's kind of the starter kit, if you will, for a newborn. And they encourage Finnish parents to have their newborn sleep in the baby box beside their bed. You can actually put it in the bed with you if you want to, but the baby sleeps in the box. Now, why do you think they want the baby in the box? So you can't roll over on it, and that's exactly right. And so it is a simple, I was saying I could go get probably some cardboard boxes and make this myself. And there are some other options out there. There's some do-it-yourself kits for co-sleepers where you can actually, you can buy them. There are always options to buy, but you can do a do-it-yourself co-sleeper where you just do some boards and build it, put it up against your mattress and put a baby mattress in there. And it allows the baby to have their own sleep space. And as this says, they're alone, they're on their back, and you can reach over and touch them. And if you're going to put them in a crib, it needs to look like that. It may look cold. It may look like you're not a good mom because you don't have the, the best bumper pad system in there, but that's what it needs to look like. And this is the message we have got to get out to our community. And this has no socioeconomic barrier to it. It is everyone needs to hear this. So any questions about that?
So Tammy, just to talk about, I mean, this is not just for us theoretical. We see every year in our community children who die as a result of their parents falling over on their. This is not an unusual.
While we were working on this campaign, and Stacy's here, she probably remembers the meeting, we were in the midst of really kind of finalizing this campaign. We had a rollover death. We had an infant who the mother, and this is pretty typical of what we see, the mother was on methadone, which is a prescribed a substance to help you if you were opioid addicted. She was not taking too much, she was not doing anything wrong, but she put the baby in bed with her. And what we know, with any type of medication that makes you sleepier than normal, you're increasing your risk for doing this. It could be cold medicine. It could be 2 glasses of wine that night. It could be methadone. And so she woke up, and the baby was cold and unresponsive. And the baby was very young, less than 3 months old. The baby was revived, but was brain dead and never recovered. And so the baby was taken off life support and passed within about 3 days. And that literally happened while we were working on this campaign. And here's the scary thing. We had 2 social workers in that home, both of whom had talked to this mom about safe sleep, specifically. So it's how do you get to those moms where I'm tired, I'm sleepy, the baby's up, I'm nursing or I'm giving them a bottle, and I just want to lay back down for a few more minutes, which is what happened. She had been up at like 5:30 that morning, feeding the baby, and then just thought, I'm going to catch another hour or so of sleep, and lay back down in the bed with the baby, and this tragedy happened. So this is not, something that's easy to talk about with moms. And I tell this story, I said it to Stacy, I have a daughter-in-law now, who's one of those Pinterest people, they're like always getting great ideas off Pinterest. And I don't have a grandchild yet, but I can guarantee you that when that time comes, she's gonna want the full ensemble, like the whole kit and caboodle. And I'm gonna have to be the bad mother-in-law and come in and go, nope, it has to look like this. Your Pinterest ideas are not gonna work here. So it's really those conversations that we need to be having. And then, I heard a lady from Mission giving, we've been working a lot with Mission on this, talk about her daughter-in-law who doesn't live locally, but in support of her, because her husband's deployed, in support of her when she gets up to feed the baby in the night, her mom is her accountability partner. And I said, how does that work? And she said, she texts me when she gets up, this is Mary Ellen, she texts me when she gets up to feed the baby, and then when she's finished, she texts me a picture of the baby back in the crib. I'm her accountability partner. And if I haven't heard from her and seen that picture in a reasonable amount of time, then I'm calling to make sure she didn't fall asleep with the baby. So it's those type of strategies that we really need to put forward in our community.
And I'm wondering if you, working with, the Mother Love program at YWCA to make sure that those young girls who are in that program are getting this information. And they need to have, I think it needs to be in the schools, period, so that people start thinking differently about what looks like love and care very early, before they're pregnant perhaps, but at least working with the YWCA and Mission Hospital to make sure that folks are getting this message.
Absolutely. It's a broad community message.
So is this something you're looking to inaugurate on L&D? And
We're looking at it as an option, and so again, we're trying to think of every possible solution. I don't think this is the solution. I think it's one solution. And recently we had a case where the social worker came to my office and I said, let me show you what you can actually buy online for $77, but I'm pretty sure you could probably figure out something like this for your client who needs a safe place for their baby to sleep, and it gave them some ideas. So we are talking about it, Dr. McLean. We've looked at budgeting some money. I think Rashida's talked about doing that in her budget to have for some of her clients, and we've actually talked about reaching out to some of our community partners who might be interested in taking this on as a project.
yeah, I can imagine Babies R Us would sell that for $40, but I bet the manufacturing cost is $2.
Probably, if that.
Yeah, we'd love to get the information out through the OBCM program. So, yeah. So if you have brochures or videos or whatever.
They are
you can use
coming.
with, great.
Yes.
This is another response to something we had talked about earlier. And I think that this is evidence that the various units are responsive to the kinds of things we talk about. And it's nice to have them come back and tell us these things and show us the results of our conversations.
So to move on quickly, I was asked to talk about some emerging issues, and I want to start with adult services. And a hot topic that we have in common with Mission is guardianship cases. I'm not sure what just happened. I promise I didn't touch anything, but here we go. So when you think about adult protective services, when you think about adult services, oftentimes what people think about are elderly, infirmed, and that's the majority of what we're dealing with as far as a population. That population has changed significantly, and especially in Buncombe County. Just as a reminder, we are still the highest provider of family care home beds in the state in Buncombe County. And we have seen a continued growth of guardianship cases in adult protective services unrelated to age and infirmity, but more related to disability related to mental health issues and untreated mental health issues. And so when you have a large homeless population and you have a large population of folks that literally just get dumped here, and I don't know how else to say it, that's just the truth. Sonia can speak to this as well. We get people who drive them across the county line, and when I say people, I'm talking about officials from other counties driving them across county lines and dropping them at our shelters and just on the streets. And then we are required to respond to that, as well as the other services in our community and the strain that puts on the services in our community. So that continues to be an issue that we see trending upwards, as you can see from this graph.
One of the drivers we really have felt will continue to feel is the Department of Justice came in and did an audit in North Carolina following a class action suit, said that North Carolina was inappropriately using adult care homes as a mental health provider when they're not licensed or trained for that. North Carolina is under corrective action related to that.
Yes. And we did have some care homes in Buncombe County that were at risk of being labeled an institute of mental disease, which means they have more clients in their care home that are there for mental health issues versus physical health issues. And so we are working with the state around those places. Another emerging issue, and Rashida touched on this, so I won't spend a lot of time talking about it, that we are seeing an increase in the number of children entering foster care. That creates issues across the board as a backlog in court system, at staff time, visitation time. But the most alarming trend that we're seeing is this increase in children 0 to 5 entering care. And if you look at that graph, we went from, I think it's 48% of kids entering care in fiscal year 14 were less than 6. And this year, fiscal year to date, it's 70% of the children entering foster care are less than 6. Why is that? And I can answer it in about one word: drugs. Drugs, 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 okay? That includes neonatally exposed infants, and we are working as hard as we can with Mission again around that. That also includes children who are exposed to drugs in their own home. And these are not teenagers who might be experimenting. These are young children who are toddlers, and the tinfoil where the residue is left out and they touch it and ingest it. These are babies who we just took a report last week that Mandy forwarded to me. Someone sent in a picture of a mom on Facebook saying, "Getting high with my kids," shows her literally smoking a joint with a child on her lap. We took custody of those children last week. So we have a lot of concern about this rising situation with these really young children coming into care. And when you're talking about drugs, that's not a quick fix. That's not a let's get in there and provide some parenting classes and try to educate and get the children home quickly. Substance abuse and addiction is an extremely difficult problem to deal with and address in a timely way. And timely meaning 12 months is what we're supposed to finish up the case, reunify or move on to adoption by the federal government standards. And if you know anything about addiction, you know that 12 months is not a long time. But in the life of a child, it's a long time.
So Tammy, that trend's true nationally.
It is true nationally, and for the same reasons. Substance abuse and domestic violence continue to be the two main issues that we deal with in Child Protective Services.
And one of the things we're seeing in our community is they're really, however you fall out on the marijuana issue, there is no pure marijuana. It's all up with something. And that's why we're seeing more and more of those kids exposed.
If you're interested, you can Google National Institutes of Health and watch some of the videos that they have that talk about marijuana and the levels of THC in marijuana. It is not the marijuana of the 60s. And locally what we're seeing, as Mandy said, is marijuana that is mixed with other substances. And so when these infants are testing positive, when these children are testing positive, it is very rare that they are testing positive for one single substance. They are usually testing positive for multiple substances. And then going on with that theme of what I've talked about, we do have a regional hospital here, Mission, and that's wonderful and so many services to our citizens in Buncombe County, but it also draws from other counties. And that means that we're responding to Mission when there are situations with other counties, whether that be adult services or children's services. And it's a significant amount of their staff's time. And if you talk to Mission, some of their frustration is they get used to dealing with us, and we have a pretty good working relationship, and then you bring in other counties, and just they don't have the same amount of time at the hospital. It's as simple as they don't know where to go. They don't know how to move around in the hospital or how to navigate the hospital. As simple as that, from going all the way up to really kind of violating some of the hospital's rules about its engagement with patients there. And so we have a regional meeting scheduled with DSSs and the hospital system to talk through some of this. And Mandy and Mission have been very supportive, and we're looking at the potential of co-locating one of our DSS social workers at Mission Hospital so that we have someone on site to respond to both our own cases that involve children and adults at the hospital and outlying counties when we have to respond for them. So we're in talks about that, and we're hoping to have some movement on that very soon. And then I've already talked about that, but we hair follicle sampled about 120 children. That means that the hair was plucked and it was tested for drugs, which is a much more stringent test than just a urine sample, and it goes back further. And alarmingly, 70% of those tested positive.
What kind of substances?
You name it, but typically it's marijuana, it's benzos, it's meth, heroin, poly, meaning many of those together.
Was this a school? Or was it
No, these are cases where it's typically been young children involved, and we had concerns, like for example the report that came in with mom holding the kid on her lap saying, "I'm getting high on my kids." or we have concerns that they are using around the children, either because they're testing positive or the social worker is seeing drug paraphernalia in the home. And we ask the parents' permission to drug test their children, and they go and they have their hair taken, and the results come back positive. That's generally how it happens. We have to have some reason. We can't afford to drug test every child that we're
No,
involved.
but I'm just saying those that are positive, it's not like 90% is THC, it's
No.
a smattering of meth
It's-
and
yes.
opioids and others.
It is, I can't think of a single situation where we've had one substance be the positive. I'm sure they're out there, but the vast majority are poly substances. Any last questions? So those are our emerging issues, and unfortunately, I don't see them changing anytime soon.
Leave the box there.
Leave
Let's
the box?
keep looking at it.
Once you spin it around.
That's just such a neat idea and so simple. And,
Jen, you can roll.
Go ahead, Jen.
Good afternoon. So in the Division of Public Health, we have two topics that we want to share with you today based on some conversations that we had with you all last year. The first one is our environmental health, where we had a robust conversation about how we protect the public safety and health in our environmental health services section. So I'd like to invite Jessica Silver up here to talk with you a little bit about what we've been doing since then.
Good afternoon. So environmental health has been very busy since the last time I spoke to you all. Some of the campaigns that we have started, we have disseminated information for the clinic's breast cancer and cervical cancer prevention program. We are also going to start on Tuesday. We have a discussion with WIC, someone from our Women and Children's program is going to come and give us information for our inspectors to give out during our child care center inspections. So that's a partnership. So some news that didn't quite make it on the slide, I think it's worth mentioning. We are working with our voice to disseminate information to local bars around drug-facilitated sexual assault. That's been a positive campaign. And we've also presented to the Asheville Independent Restaurant Association concerning inspections, what we consider priority foundations, or those items that we note on inspection that the CDC has identified as a risk factor for foodborne illness outbreaks. That was a pretty positive meeting, and that's something that we want to continue to have, to open up that conversation with that important group of people that we serve. As far as collaborative efforts, we have disseminated a bed bug video and also started a bed bug meeting, bed bug meeting of the minds, I think. Right? So one of our goals.
Where's that hell?
Where's that hell? Would you like to repeat it?
We're just trying to get them all.
Right, all in one place so we can just eradicate them for once and for all, right? So the hopes with the Bed Bug Summit is that we can call all of our community partners. That includes various lodging establishments. We want to involve Mission Hospital, the nursing homes, any communal places where people can come and not necessarily just sleep, because you don't think about bed bugs in movie theaters, but that's a place where you can pick them up. And there are no, sorry, so cancel the movie for the weekend. No, but bed bugs really, there is no socioeconomic divide, and they do not discriminate with who they will attach onto. Yes?
Are they vectors for disease?
No, they are not vectors for disease. They are really, once you get them in your home, they're really hard to get rid of. So part of our partners, one of our partners with the summit would be some pest control companies to talk about different methods that they use, the most Effective method to get rid of bed bugs outside of chemicals would be to heat the whole house. You have to heat the house, I believe it's up to 140 degrees Fahrenheit. So they seal the windows, they seal off the entire living space, and basically cook them and fill that all. Yes.
I was just going to comment back to the earlier emerging issue around family care homes, that having those folks attend this summit or some requirement that they receive that information would be really good.
And so as an environmental health specialist, you should try, I've had to have a conversation with family care homes before where the bed bugs are located in one room. It's hard to persuade them to keep that client in that room because if you move them, then they spread. So I think that's a great idea, and that's definitely a partner that needs to be at the table.
So I know we laughed about movie theaters, but are you involving movie theater in this as well? Because that's almost a public health issue. If I go to a movie theater and end up with bed bugs, I'm going to be pretty upset with that theater. So
Not only that, yes, but when we met our first time, we developed a list of people that we need to bring to the table. Those are one of the people. We also need to think about school systems. They come in on backpacks. So think about that. You send your child to school, fine, and some weeks later, you wake up with spots or sores, and you find out you have a bed bug issue, and you think back, where did it come from? And so who pays for that? And what resources are there? Because it is pretty expensive once you bring them home. Once they would
move in.
Yeah, they definitely move in. They multiply. So the bed bug summit is going on, and I think that's a great idea. We have public information sessions planned. You all have requested the septic system 101 meeting. Yes. So that's going to be coming up in the fall of this year. We're pretty excited about that. We decided on the fall to give us time to rebound from our summer rush. To be completely honest with you, the weather has been so nice here this winter. We never really had our decline in septic system requests the way that we normally do. So we're hoping that the fall will be a good time to have the septic system 101, where we'll invite contractors as well as homeowners or anyone with the septic system so they can learn more information about that. One thing that's also new that's not on the slide, we have created a well information pamphlet that goes with everyone that applies for a new well permit. A lot of people that come in and request a new well permit, they didn't realize that a water sample is included with that permit. So now they're getting that information, and hopefully they're actually reading it and learning how to take care of their well, and also going to follow up with the testing that we offer. So we have had quite a few emerging issues. The most glaring is the North Carolina legislators push to provide an engineer option for septic permits. Basically what this says, the way the law is written, because we don't have the rules yet, the way the law is written, anyone that's wanting a septic system will be able to go to a licensed soil scientist or a licensed geologist to do their soil work, and then an engineer can design the septic system and oversee the installation of the septic system. We think this option is going to be much more expensive than coming to the health department, so we don't really, this is the general consensus of environmental health departments throughout the state. We don't really see this being functional for the day-to-day homeowner, but if someone has a large project, a private project, let's say an apartment complex is going in and they need a septic system to fit those families in those bedrooms, then an engineered option may go faster than working through the State Department of Environmental Health for that. So this is a new law that was just passed in October. And so that means the state is now working on the rules for that law. The rules tell us as environmental health specialists how to regulate that law. So we're hoping for temporary rules by June of this year, and permanent rules won't be available until January 2017. Yes.
What's the real speed it up, speed the process up?
That's what I understand. It was to push forward with those projects. Local environmental health departments, we can only look at systems up to 2,999 gallons per day. So it's pretty a small system. The State Department of Environmental Health, they have to design systems larger than 3,000 gallons. And the state has always had a way that you could, they don't call it paying, but basically someone applying to pay to get their application moved up. Imagine that. So I think this is a push to further that. What the health department's responsibility in that will be, from just reading the law without direction about how to do it, we have to attend a post-construction conference. The homeowner has to supply environmental health a copy of the engineered soil septic system report, and then we have to maintain that report in our system somewhere. So we have, as it stands now, environmental health has 3 responsibilities in the engineered option. And incidentally, with that in the law, they included how much we can charge. We can only, to do the engineered option, we can only charge 30% of our standard fees. So right now that would mean we're doing a post-construction conference. We are providing any type of, not necessarily installation oversight, but we can make inspection visits, but not necessarily create a report, which I think is really interesting. And we will house that for about $118. So that's 30% of what our current fees are.
And most single family homes would be under that 6,000.
Yes, most single family homes are under 3,000. Unless you go over like 10 bedrooms. So a standard 3-bedroom system is 360 gallons per day.
Okay.
So, anything else? Oh, I'm sorry, I left right. No. I have 2 more points. Sorry. So in 2013, the legislators also voted that if a private club has an ABC permit that's held as private club, mixed beverages private club, so if a private club or restaurant has a permit, an ABC permit that says they can sell mixed beverages as a private club, then environmental health no longer has the authority to regulate that facility. So what that meant for Buncombe County is we had 18 facilities or restaurants or bars that we were inspecting that we had to close out of our system. They're not closed, but as far as we're concerned, we're no longer regulating those establishments. We are also, any questions around that? So if you go into a bar, I know, we don't like it. We really
So
don't
if
like
they
it.
call themselves a private club, that gets around the regulation.
They can't only call themselves a private club. They
It must
have,
be
when they
licensed.
apply for the ABC permit, it has to specifically say on that permit, mixed beverages private club. If it does not say that, then we are still there. But don't be alarmed if you go out to a bar and you don't see our grade card anymore, because they may be one of those 18 establishments.
Well, if they're a private club, wouldn't they have to announce that? Wouldn't they have to advertise themselves that way? Wouldn't they have to have someone checking memberships at the door? I mean, there are some things that I would expect if it's a private club that would be different from a public establishment.
So you are asking the same questions we asked.
Oh, excuse me.
So I will tell you what our directives
Directive.
Yeah, so you're on the right path. So I will give you the clear-cut version of it. When this was done, who knows what the motivation was behind it, but in North Carolina, there's an environmental health specialist in every county. There are 2 ALE officers that would go into a private club to say, are you really a private club? 2 for the whole state. So, I'm gonna leave that. Any other questions around the private club? Okay. So we're still working with our rabies prevention and control group. That's been an amazing group of people that have been coming together. Dr. Oliver has been attending. We've had some great discussion. The latest request that I made from the group is for them to provide their their ordinances with the different municipalities. Most of them are police, local law enforcement agencies or police departments that are responsible for ensuring animal control in their different municipalities. I've requested that information so the next time we get together, we can talk about how there's some overlapping policies so everyone understands who has authority and what their authorities are, and what Jan's ultimate authority is as the health director for the county, and see how we can work together better. One of the biggest goals or biggest, the biggest things that raised my concern was that in the county, not all municipalities provide the vaccine to their officers that are responsible for responding. So that means if the officers are exposed, then they're going to have to go through that post-treatment trophy. So we would like to, as a department, recommend and send a letter of support of those municipalities offering that vaccine on the forefront to their officers or their first responders as opposed to giving the post-exposure treatment. That's what we are. Questions? Thank you.
You can talk about anything on the service. I feel like she was handing me the paper. So I'm going to talk quickly about just following up on our communicable disease topic. So we had that one session where I brought forth a sort of complicated communicable disease situation where we have people who living with HIV or some other communicable disease, and we have difficulties maybe finding them placement that is good for them, but also providing them services that will keep the community safe. So we had our discussion, and based on our conversation, we ended up utilizing kind of a modified threat assessment team approach where we pulled together everyone possible who was connected to a particular person because an incident came up following our meeting. And so we had our agency staff, we had Vision Hospital staff, we had the LME CMO who was involved, we had the guardians, all kind of around the table or on a conference call, and we sort of just hashed out the problem. And it went really well, and I think, just getting everybody in a room together to sort of talk about here are the issues, here's what each person can contribute, it just really kind of sped up the process of figuring out what are the possible solutions and then sort of lighting the fire so that things weren't being cast aside. And it ended up, it worked out. The situation, our mental health system is not ideal, but with the resources we had, we were able to put a program in place that is serving this individual and helping protect the community. So we're going to continue to utilize that model, but I would just say, just remember that those complicated cases exist, and so if you can do anything to advocate for, improved mental health, substance abuse, right? That's always going to be a major issue. Emerging issues that are coming our way. So the state is has been tossing around this idea, and it looks like this year will make a decision on whether they're going to make chronic hepatitis C a reportable disease, which if they do, will mean that the work for our communicable disease nurses will skyrocket. We have significant numbers of hepatitis C, everywhere, but especially we feel like in the western part of the state. And so the state's meeting with local health directors, they're meeting with FQHCs. They're meeting with people that are going to be impacted by this decision. So we expect a decision to come maybe later this fiscal year. We're also seeing the states pushing out some information about an uptick in acute cases of acute hepatitis C, and all this is really tied to injection drug use. And so, again, there's been a lot of conversation recently about what is the role of needle-syringe exchange, and is there going to be a greater push, locally, and then also like in the state to maybe talk more about that, because it's currently not legal in the state of North Carolina. It's kind of a gray area, but there was that outbreak in Indiana with HIV related to injection drugs, and the governor changed the law there to allow that county to have needle exchanges. So I think that's kind of started the conversation throughout the country. So we'll be interested to see that, and maybe something to look into if you're interested about the evidence behind the needle exchange. Travel-related infections, so that's always a big thing. 1 year it was chikungunya, last year was Ebola, and this year it's Zika. And so that always, while they're not necessarily on the list of reportable diseases, the state, we constantly are pushing out information to providers and saying, we do want to know if you think you have somebody with this. So again, that's extra work for our communicable disease nurses, and also communicating with the community, with the providers, making sure that they have the information they need to address these infections. And then there's been some discussion about, we do have mosquitoes in Western North Carolina, and what is the potential for these infections to be taken up by our mosquitoes and spread. And so looking at our mosquito control programs in the state is an important issue. And I know the state just now posted a position for a medical entomologist, position they have not, it has been vacant at the state level for a while now. And then finally, just dealing with a potential nurse shortage. This is not a thing that's unique to public health, it's affecting all of us, but public health work is a little different. And so how do we, when we have the need to hire more nurses, how do we make our work appealing to that population? But then also, how do we support the community that we have enough nurses to take care of our population? So that's kind of stuff we're working on. Any questions?
Thank you, Dr. I don't know if all of you heard me, but I awakened early the other morning, and as I was turning the television on before making coffee, Dr. M was there talking about mosquito viruses, and I just sort of stopped immediately to see what she was going to say because of my involvement with HHS board. And I applaud you. You were very clear, and I thank you for getting up that early in the morning to do that kind of thing.
Good afternoon. I'll try to go through this fairly quickly. We not necessarily been working on a baby boxes, but just a couple of things. Our participation in FNS has really leveled off a lot. Our caseload actually has started to decrease a little bit. Medicaid has continued to increase. Doesn't mean our workload has decreased. Ultimately, we're still probably receiving the same average number of applications for both programs. There has been an increase in cost around performing eligibility functions. We've talked a lot about NC Fast. I think everybody's read about NC Fast or heard about NC Fast. We did some time studies around the work in NC Fast versus the way it worked existed in the old systems. And for most actions, we see that it almost doubles our time for each action. There have been revenue increases associated with Medicaid eligibility due to the Affordable Care Act. Ultimately, before the Affordable Care Act, we were reimbursed at a 50% federal level, 50% county level for Medicaid eligibility. With the ACA, that is now 75% federal level, 25% county level. And what ABOD stands for is able-bodied adults without dependents. That is a policy that goes back to 1996 with welfare reform. It is a policy around food assistance. And basically what that policy says is that if you're an ABOD, that you can only receive food assistance for 3 months out of a 36-month period unless you're working 20 hours a week or doing some activities in 20 hours a week The state's been on a statewide waiver not to institute that policy since 2008. It is back. It is back in Buncombe County as of January the 1st of this year. 23 counties instituted that policy back. January 1, the other 77 counties will come on board July the 1st. So all 100 counties will have the policy back July 1st. What I'll tell you from our perspective is that we knew that that was going to occur. We put in last year to become what they call an employment and training county and started drawing down some federal dollars for that. We have contracted with Goodwill because we already had a contract with Goodwill that would provide employment services for our work first population. We're also using them to provide case management, assessment, and employment services as needed for this population also. As we identify these individuals, we are referring them to Goodwill, and we are doing case plans and assessments for them to provide them a path to comply with the policy.
How would you I know this is an unfair question, but how would you characterize these folks?
There are some exemptions.
Yes, and there are many exemptions, and some exemptions that there was clarification from USDA this year that at times when this policy has been instituted, those exemptions didn't exist. And a perfect example of that is USDA came back this year when we started back with this policy and said people who are chronically homeless are exempt.
Even though they're able-bodied.
If they're living in a shelter, they're exempt. And that's an exemption that has not occurred in the past when this policy has been instituted. There's a number of them. The number of able-bodied adults that potentially may be into this category in this county, it ranges. We've done numerous reports. I don't know what the exact number is, anywhere from 1,500 to 3,500 individuals.
So what you're saying is if I come into you and apply for aid for food stamps, and you then do an assessment on me, and if you determine there are no other contributing factors, that I am indeed an able-bodied adult, then that's it.
And that would be correct.
That's how I get in the system.
And then you could receive food assistance for 3 months.
3 months.
And then after that period, if you are not meeting the requirements, meaning 20 hours of work, or 20 hours of education, or 20 hours or a combination of multiple factors, then you would not be eligible for food assistance.
And the system that Phillips built through that contract is offering some employment training in case management.
Our goal is to hit those people when we first determine they meet that possible criteria, to do an assessment with them, to provide the case management services that we develop a plan for them to say, here are the steps that you can take to comply.
But, do you think there's, in this population, maybe a significant substance abuse problem or developmental disability, or are they maybe have marginal medical problems that don't, why do you think they're having trouble with employment?
Many of the things that you mentioned would exempt them, and really the exemption is about being unfit for employment. That's kind of the terminology that's used now. And many of those things would exempt that individual during that time.
So you do have some tools.
Correct.
And can, in some instances, use work studies or community service versus paperwork, depending on the individual. And I think this population, we've had a contract for several years with Is Illegal around identifying those individuals who may qualify for disability and providing support to them in that process. This is a group where we think we will identify some of those individuals who may meet the definition of disability.
Any other questions? You're not finished yet.
One quick, I'll go through this real quick. The state is actually under, in trouble with USDA around timeliness issues for food nutrition program. Have to meet a 95% timeliness requirement from January through June of this year, or stand to lose. In the neighborhood of last year, $75 million administrative dollars. And for Buncombe County, it's a lot of dollars. 7.9.
So that means getting people on the service.
We have to approve applications, 95% of the applications within their time standards, which are 7 days for expedite, well, it's actually 4 now, and 25 days for regular days.
And think of that in the context of what Philip said about everything we do in NC Fast takes twice as long. And while we've seen a plateau in FNS, the growth from 08 to current is 102%, just from a caseload perspective.
So Phil, on that one, you said that the state is under that warning, but it's really 100 counties that have to do their part.
That is correct, and the 10 largest counties comprise about 50% of the caseload.
Is it possible to achieve
No, that's not
compliance with
actually a
that
good
new
thing.
system? The fact that it's doubling everything, I mean, is that how much of a factor is the system?
It's a huge factor, the system, and North Carolina, for whatever reason, for years interpreted the 7 days expedited, 30 days regular, incorrectly, because it has to count for mailing. So we also lost, as Philip said, 3 days on expedited. It's now 4 days from the time we get your application and information to process it, for 25 on your regular 35 days. I will say, Philip's team's working incredibly hard at that, and we've hit it. We're certainly the highest performing urban county, or tied with Catawba on and off.
We've averaged right at about 95% over the last 2 months.
But we've invested, and Jim would have to break down that number, $3 million, more than about $3 million county dollars in additional resources to do.
So when does the clock start ticking on this? Once they have provided all the information, their application is complete, or is it when they walk in for the first appointment?
The minute they walk, the minute we get an application. So
What
if it's mailed to us, it's the minute we receive it in our mail room.
Even if it's incomplete?
Absolutely.
That's
If
great.
it's signed, according to USDA, it's complete.
Okay, thank you.
And here's how you apply. So I don't remember that number. Do you, Philip? No,
You're still waiting to hear, right?
We ended up with about 2,800 applications.
Depending on time, we've got a written. Okay, we'll give you a written update on these 2 major projects. What we're trying to pay more attention to as an administration is those major projects that the county assumes, or Health and Human Services assumes, that impact numerous departments, not just Health and Human Services, but finance, IT, and our multiple year financial commitments for either us and or the county. 2 of those that you know of are the Family Justice Center, which is still targeted to open in August. Have a potential date for an opening, but it's still scheduled to be full service and open in August. And the second one is 356 Comprehensive Care Center, which is a 24/7 urgent care center, and you've seen presentations on that. And Jim, you want to update on timelines, just briefly on that?
Sure.
Runs lead for us on that.
There are 2 components to the family, to the C3 356. The first component is a behavioral health urgent care, which provides 23-hour beds for folks that are not in a crisis situation yet, but it allows them to get stabilized in that situation. And also a peer living room model, which is a place for folks to be able to come to have behavioral health concerns or issues either with themselves or with their family, to be able to meet with folks that can provide their peers that have had that experience and come through that. That actually is scheduled to open probably around April, 1st to mid-April. The facility-based crisis component to C3-356 is currently being provided at what is the Neil Dobbins Center at the campus where Minnie Jones's clinic is located. That construction is beginning now with anticipated early fall, that transition will happen where that will go to 356 Biltmore. So they'll have RHA Health Services, who's providing behavioral health services on the top floor for adults, and on the ground floor will be the behavioral health urgent care, the peer living room, and the facility-based crisis unit. So that will be a big place where, as you've heard, for drop-off from law enforcement, EMS, and hopefully provide a lot of diversion for the emergency room and be able to provide care for those folks so that they don't have to stay in an emergency department for an extended period of time.
Before you sit down, just if you or Dr. Mullender really quickly would talk about one of the other issues that came up in our meetings was around families' ability to access lice treatment. And you would, well, have worked with Evelyn to make that available to both school systems. We'll be glad to know that. And where individuals can have access at any Ingalls, and then that gets vouchered back via Evelyn.
So they'll actually, Evelyn will pay for that through Ingalls for them to get that treatment, since it's not a prescription treatment.
And focused on knowing that it just causes exposure in the school system if we don't provide that support to families who can't afford it. I want to say just in closing around this part, and I just have two quick announcements, is, you know, one of the things the board talked about is if you look under North Carolina law, boards of social services and public health and consolidated health and human service boards have very limited authorities. In North Carolina, we operate as a state-supervised, county-administered system. We don't have any authority over case decisions or policies. We implement primarily federal laws, state laws, and policies, and we are state-supervised. So the board has really talked about, with the exception on the public health side of the ability to write some local public health rules, as long as not more stringent than state rules. So your interest as a board was, how do we have impact when we really don't have authority? We don't have authority over who's hired or fired in the system. You don't have authority over the laws or policies or service delivery. So I think this board has done an amazing job, and just want to acknowledge that. And I think today's an example of that. Of saying, okay, how do we have an impact in our community? And I think these are examples of the impact you've had. I want to share two quick things. I know this date because we arranged for the meeting space, but April 6th will be the public hearing on Medicaid reform in Asheville. That's held in Asheville. It'll be held at the Event Center at ABTAC, 6:30. So you can get that on your calendars before the public notice goes out on that. The other thing I just want to mention is that yesterday, Legislative Oversight Committee on Early Education and Family Support heard from experts across the spectrums on access to child care, pre-K, and early education initiatives. And Philip was one of two DSS representatives in the state who testified related to child care subsidy. Smart Start was also represented, as well as North Carolina pre-K, child care providers, and developmental pediatricians who talked about the importance of those programs from a developmental perspective. I have and will send out to you both Philip's statements as well as the notes from that meeting, because I felt like if Philip can feel free to offer that the recommendations were very well received on Legislative Oversight Committee yesterday.
Could you just post them on our website?
I'd be glad to post them on our website.
efficient.
And those are my own.
Well, thank you very, very much. Are there any other items before we, one of the things that we have done since I've been chair is we've had on our agenda an opportunity to comment. We haven't had any, and we're really not obligated to have public comment. I mean, that's not a requirement for us, because we are an advisory board. So in that context, we didn't put it on our agenda today, but we do have two people who have asked to address us. The first one is Christopher Husney. And we will use the same rules that we've had previously. When we've had public comment, you have 3 minutes to present.
Okay, I'm gonna let her go before.
Okay, but then, would you come up front?
Sure.
The other person is Christy Sluter.
Oh, that would be me.
Okay.
Yeah.
You come up front, please. You have 3 minutes.
Thank you very much. And I appreciate y'all's time this afternoon, and hopefully I won't take more than 3 minutes. I appreciate the hard work you guys are doing in this community to make the lives of the children safer that we see and serve. I've got over 20 years of serving families in this community who experience substance abuse, domestic violence, and have issues with homelessness and lack of resources and all the fun stuff you run into with families who have a lot of needs. I am a clinical social worker and a clinical addiction specialist. I've worked with a few of you, and I've worked for at least one of you here. But I am doing my best to bring this message to whoever will hear it. We have the capacity to improve the protectiveness of the children we are serving in this system and spread the risk of making right decisions regarding these children when we spread out the risk with collaterals. What I'm seeing over and over again is where collateral contacts with families who are experiencing substance abuse or domestic violence, or where there are personality issues, are lacking. We are lacking collateral contacts. And what I mean by collateral contacts is people who are associated with families, whether it's neighbors, bosses, relatives, extended families. I've got one aunt that spent $30,000 trying to protect a child that we as a system were involved in, and I'll take responsibility for it too. I've got another one that spent $20,000, and this is really unnecessary when we have the authority and the power to make this easier on these family members. Today I heard about listening to the community. Mr. Husney, my husband, and I, along with others, are members of his community. And as collaterals, we made ourselves available to discuss issues with his particular case. And that was, unfortunately, fell on deaf ears, and now we have recidivism happening in that particular situation, which is not uncommon. Everyone in a family system where there is substance abuse and domestic violence and personality and mood disorders, there's no winners in that system. Everybody needs treatment. And the right treatment it's hard to find the truth closed within that family system. Am I out of time?
Yes, you are.
Collateral contacts, just please keep that in mind.
Okay, thank you.
Thank you.
Mr. Husney?
Thank you guys for your time. The case was, an allegation was made on my family and me.
We cannot discuss any specific cases.
Okay, I'm not set it out. However, there were some allegations made on me. I just want to know, where does it begin in the investigation where someone follows up to find out whether these allegations are true or not? They obviously weren't, yet they were substantiated through the department to be true. I don't know anything about policies, what the rules are, you guys, that you have to do before you can substantiate a case, but I would think you would have to talk to at least several people that know me as a person. No collateral contacts were made on my behalf, and all I'm here for is my children. They're in a real bad situation now. They don't have a father. The mother is on drugs, expressed my concerns at the social meetings, and nothing ever came of it. Now that the case is closed, the children are on drugs. They're with adult boys and they're very young teenagers. The mother's on drugs. She also tested positive during this whole case, which seemed to didn't matter to me. So that's my concern. It's not to throw anyone under the bus. I just know that somewhere in the beginning of these situations, someone has to do their job and go to collateral contacts and find out about who they're dealing with. My wife has a long history of mental health abuse, mental health problems in which she cannot tell the truth. Everyone believes her. So that's kind of where I'm at.
Well, we appreciate you coming to speak with us. We are not supervisors of the departments that operate here. If you have a complaint against the Department of Social Services and how they handle the case, your alternative is to call the State Department of Health and Human Services and report to them. And I can give you that number if you'd like.
Sure.
Thank you. Are there any other items to come before us today? You know, I'm real time urgent. We are right on time. Meeting is adjourned.